this valuable session, Dr. Yasser Shouaib, and deep thanks to my dear professor, Dr. Mohammed Badr, the man who created the endoscopic ear surgery in Egypt. And last but not least, let me welcome our high-profile guest, Dr. Stephen Ayash in Egypt. Today, I'll talk about endoscopic staphyloctomy, and here I want to ask two important questions: why and how? Staphyloctomy is done in most centers around the world by using the microscope with excellent results, and this is a fact. Our thesis published in Journal of Pathology revealed that both endoscopic and microscopic staphyloctomies have an excellent post-operative audiological evaluation with no statistically significant difference between the two groups. This will raise an important question. Do I need to practice endoscopic staphyloctomy? And this is the question, why? Depending on the detailed panoramic view of the endoscope, my answer to the biggest question is, without any hesitation, absolutely yes. It minimizes complications, offers solutions for many problems, and raises the medical education learning curve, and which is the first important point. How does it minimize these complications? Regarding tearing the flap, the use of the endoscope enables us to visualize the annulus and the middle ear mucosa obviously, which minimizes the incidence of tearing the flap at this site, which is the commonest site to tear the flap during the elevation of the tympanoid flap. Here I can show the annulus clearly and the middle ear mucosa and elevate the flap safely. Early detection of abnormalities and confirmation of the diagnosis by testing mobility without need for curating bone decrease the morbidity. This video showing us an abnormal middle ear anatomy which is seen just after elevation of the tympanoid flap, and this video showing us the ability to test the mobility of the articular chain even before complete the elevation of the flap. Here. Regarding correlative benign aging, this video showing us that the use of the endoscope enables us to curate the bone just near to the correlative benign nerve safely and very safely, and you can deliver the nerve and release it from its conic canaliculus to widen the access to the foot plate very safely. Here, by using the endoscope, you can handle the correlative benign nerve safely and use it to support the different vessel after insertion around the longus processus of incus in its place. The bottom line here that the role of endoscope in saving the correlative benign stands out in cases where the nerve of the other side was injured in a previous operation. It's already known that perforating the foot plate and the insertion of the prosthesis are the most hazardous steps. So, by using the endoscope, you can see the exact size and size of the perforation of the foot plate, and you can be sure that your insertion of your prosthesis is in a right manner, and even you can correct the position of the prosthesis if faulty insertion is happening. It's easier than you think by doing it by the endoscope, indeed. Using the endoscope in staphyloctomy offers valuable solutions to obstacles we encountered during the procedure. The advances in using the endoscope help staphyloctomy to be easier in non-tortuous canals and pediatric population. This is a famous diagram that's showing us the difference between the trans-canal approach by using the endoscope and microscope, as the endoscope can bypass any constriction of the canal and get nearer to the target structure and give us a wide field of view. Here, there is a case of staphyloctomy which I started by using the microscope, but due to the narrowing of the external dental canal, I shifted to use the endoscope indeed to get a near and detailed panoramic view of the surgical field, as we see in the operation here, the long process, facial nerves, stapedius muscle, and pyramid. But you can see, but you can't insert, to be honest. So you must curate some bone to widen the access to the foot plate to make your insertions easier. Here, in the insertion of Teflon piston, with stable superstructure in place to give some stability to the long process of the anchors during the insertion of the Teflon. As regard to pediatric population, let me show you this case. Here, there is a case of endoscopic stabilotomy for bilateral congenital stapedial fixation in a 7-year-old child. Here, the preoperative pure tone audiometry. This video is showing us the right endoscopic stabilotomy for this child. After elevation of the panometal flap and curating the bone posterior superiorly to widen the access to the foot plate, we made a perforation in the foot plate by manual perforator. Then, Teflon piston insertion was performed with also stable superstructure in place for the same previous reason I told you. Here is the insertion of the Teflon piston under vision and with ease. Here is the post-right endoscopic stabilotomy pure tone audiometry. After 7 months, we shifted to perform the left side by the same technique, which is left endoscopic stabilotomy, with using Teflon piston also, and with preservation of the stable superstructure during the insertion. And here is the final pure tone audiometry after bilateral endoscopic stabilotomy for this child. By using endoscope, you can face any unpredictable pathology. This is a case of revision stabilotomy. After elevation of the panometal flap, we found the prosthesis in place, but the vesicular chain was fixed. So, after drilling the outer attic mass, we revealed that there is a frozen attic with new bone formation between the head of the medius and the outer attic mass. After releasing the new bone formation, we got a freely mobile vesicular chain. How can I do it without a scope? I request. Here, there is a case of fascial nerve overhang on the foot plate. After elevation of the panometal flap, we found that the tympanic segment of the fascial nerve overhang partially on the foot plate. So the space was very narrow. So I fractured the crura and make the perforation by manual perforator. Then the insertion was performed. In April, in Modena, I attended a similar but more difficult case in Modena, which was performed successfully by Dr. Levi Presutti, and I think that Dr. Ayash and Dr. Bat remember that case. The use of the endoscope in stabilotomy increases learning curve, especially for the attendees, which is a very, very important point of using the endoscope here. By using zero endoscope or 30 degree, we can get a detailed panoramic view with full orientation of all endoscopic landmarks of the middle ear. Here the cochleariform process, the tympanic segment of the process of the incus around the chamber, and by introducing the endoscope anteriorly, we can visualize the protimpanum. Here is the tensor canal, subtensor recess, carotid prominence, protiniculum, which is the border between the protimpanum and hypotympanic. Here is the hypotympanic ear cells with round window with false membrane. Now, if I decide to practice endoscopic stabilotomy, so what is the play? And this is the second question, how? The best way to upgrade your skills in endoscopic ear surgery is to attend a cadaveric dissection course, and this is a fact. However, it's quite challenging to be achieved in our developing countries regarding the high cost and availability. Fortunately, Modena team offered us an applicable alternative by using the cheap ears. Although not ideal, yet it achieves the same goal. 3 tasks to be performed according to Modena course: tympanometal flap elevation, tympanoplasty type 1, and cycloplasty. Fortunately, I managed to add stabilotomy task to Modena course to be performed. Last year, 2 workshops with hands-on cheap ears dissection were moderated by me, and I'm honored that the second one was headed by my dear professor, Dr. Muhammad. May I advise? First, try to begin with right-shaped external canals like this canal, and you are lucky if you find it. Second, may you start with 0 degree endoscope for easier manipulation of the instruments through unchanged anatomy orientation. And start with 2.7 or 3 mm diameter endoscope, then later you can use the nasal endoscopes with 4 mm diameters, which are routinely present in our hospitals. Also start with endoscope with 14 to 17 cm lens for giving space for your working hand, as shown in these photos. Third, I am a beginner and I am right-side-handed. Is it easier to start to operate endoscopic stabilotomy in left side or right side here? And this is a debatable issue indeed. On one side, Lina McGraw in 2013, regarding doing endoscopic stabilotomy, she reported that the right ears are easier than the left ones for people formed. On the other side, Daniel Lee in 2016 stated that endoscopic ear surgery for the left ears is easier than the right ones for the beginners. From my point of view, both were right. My own diagrams for the diopter axis by 0 endoscope is showing us this fact as follows. This diagram is showing us right eccentric canal, and the red rectangular shape is showing us the range of mobility, range of movement of the endoscope inside the canal. By putting the diagram in the same position that the patient is lying in front of us in the operating theater, it seems like this. The yellow arm is referring to the endoscope, and the brown stick is referring to the working instrument, which is here the first incision knife. Please note that this goes over between the endoscope and the working instrument, which is making the instrument working hard. So you must be obliged to withdraw your endoscope externally to let the working instrument work in ease. This is making the vision obscured. After complete elevation of the tympanomeatal flap and reaching the posterior part of the middle ear, please note that the working instrument is a little bit away from the endoscope, so you can introduce your endoscope deeply and make the vision more clear. Here, the surgeon in both operations is right-side-handed. Please note that the axis of the insertion on the right side is a little bit away from the axis of the endoscope, which is making the insertion easier. So I suggest that the insertion on the right side is easier than the left one. So if you are right-side-handed, please start with left ear for elevation of the tympanomeatal flap and curving bone, but start with right ear for performing the insertion of the prosthesis. Fourth, save your neck by keeping the monitor at your gaze or even let it blow, either you're working sitting or standing. Fifth, the endoscope holder. Is it beneficial or not? From my point of view, you may need to hold the endoscope in your hand, especially in the middle ear, to change its direction and distance as you need. But it may be beneficial during the tympanomeatal flap elevation, especially for the beginners. Sixth, injection of adrenaline 1 to 100,000 is very important for good hemostasis and hydrodissection. Seventh, unfortunately, the endoscopic view is a two-dimensional image without depth of perception. So I suggest to put your instrument on a fixed, hard bony landmark at the outer aortic mass at the beginning, then start from it up and down. Eighth, the instrument is your tool. So please choose the right tool for the job. Try to use one instrument for multiple purposes to save the time. Here's our single knife, which could be used as a scissor by its sharp blade, or a needle by its tip, or a dissector by its blunt blade. Your angled instruments are far more better in performing. Ninth and finally, keep the microscope ready till being so familiar with the endoscope as you may shift to it to overcome any difficulty you may be confronted with. Finally, please take home message. As regards to stabilotomy, the endoscope has many privileges. Over the microscope, that is still a good tool. So choose your way, but be professional and score your goal. Finally, may I invite you to join us and participate in our next activities of the Egyptian Working Group in Endoscopic Ear Surgery, with the photo of the members of the group headed by my dear Professor Dr. Mohammed Bat, and here is the board of the Egyptian Otorhinolaryngology and Burst Society. Our WhatsApp group admin, Dr. Osama Husseini, Here is our Facebook page. And for scientific activities and coordination of workshops, please contact me with pleasure. Thank you.